Hey guys, and welcome to Clinical Physio with me, Phil Richards. Today we're going to be talking about testing active range of motion of the hip joint. We're going to be talking through the actions you need to do and the muscles that drive those actions. If you're not familiar with why we test active range of motion, we suggest you look at our video titled Why Test Active Range of Motion for the full clinical reasoning process for why we do this. So as to not slow your video down, we're not going to be comparing the affected and unaffected sides in the next video. But of course, in clinical practice, we always want you to compare both sides because it can really inform your reasoning process and how you continue your assessment and treatment. So when we're thinking about active range of motion of the hip joint, we want to consider three things: P, Q, and R. That's for pain, quality, and range. If you're not familiar with P, Q, and R, here's the recap. If you are familiar, then move along to the next video and we'll see you then.
So as we have said, when testing active range of movement of any joint, we need to consider P, Q and R. P for pain, Q for quality of movement, and R for range of movement. In terms of pain, if pain is present, we know that there is a dysfunction within this movement, which may be causing our patient's problem, and will likely direct further testing to this area to try and isolate the source of the pain. If pain is not elicited as part of the examination, the therapist can move on to the next stage. For example, if there is no pain on active lumbar spine movements during a hip examination, the lumbar spine can be ruled out of the initial investigation. In terms of quality, good quality indicates that the brain and local tissue are both happy and able to perform the movement. So what does that look like? It means that the patient will look very willing to move and have sufficient power in movement with good control and coordination. If these are lacking during the movement, quality can be questioned, and thus likely direct further testing to establish why the movement is of poor quality. For example, weakness, which could be due to a myotomal weakness from a spinal pathology, or a deconditioned muscle from the local area. In terms of range of movement, too much or too little range can indicate a dysfunction within the movement, and could also help us identify the patient's condition. As a therapist, it is always important to use the range values within your movement test as objective markers and for you to compare the specific range values in each treatment session. It is important to note the range at which your patient's pain starts and the range at which the movement ends, as often these two values will be very different. For example, if we only measured the movement at which pain starts, we do not actually know how much range the patient can achieve. Essentially, a lack of range indicates that there is a stiffness or a weakness which is preventing full movement.
So let's quickly go through certain assumptions we can draw with regards to pain location in the hip and what pathology it might be. So you're instantly thinking about what this could potentially be when your patient comes in, instead of thinking, oh, panic, 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 what am I going to get through? So for instance, let's break this down so we can make it nice and simple. If someone has anterior groin pain, or as a hierarchy of thought, we're going to think it's more likely to be hip, less likely to be SIJ, and even less likely to be lumbar spine. And if we were thinking of the hip, we would be thinking of something like arthritic change, impingement, or less likely but still very prevalent, some sort of hip flexor tendinopathy. If the patient had a complaint of pain in the groin and it was very much more midline at the top, we would be probably thinking adductor tendinopathy. So that would be your main ones for the anterior aspect. With regards to the lateral aspect, time and time again, people will start to point around the greater trochanter, and instantly you'll be thinking, greater trochanteric pain syndrome, which can be a referral from the hip joint, or likely to be an abductor tendinopathy. So there will be your main ones thinking there. It could also be the deep stabilizing muscles of the hip, but we're still thinking hip. You are less likely to see a lumbar spine or an SIJ referral into the lateral aspect like that in isolation. Posteriorly, we'll be thinking more about lumbar spine, still the hip joint, and more likely SIJ in this instance relative to the anterior aspect. And they're the things you want to keep in mind as soon as they say, I have pain here or here or here. So now we're going to look at testing active range of motion of the hip into flexion. So as a therapist, we're going to stand beside the patient, and the patient is going to be supine. From here, we give the instruction, can you bring your knee as far up to your chest as you possibly can, please? And that gives us our our active hip flexion. From here we need to obviously do our overpressure. So our handling for this is going to be supporting either side of the knee on the lateral aspect, because what we want to do is control the knee here. We might, depending on the age of our patient, for instance, they might have an irritable knee anyway, so you don't necessarily want to be causing additional flexion. So we're just going to hug around the side, keep our posture upright and lean in with our upright spine to provide that overpressure and relax down. And I could see a little bit of almost a wince in Polly's face then, so I would instantly be saying to this person, did that hurt around the top of your groin when I did that motion? And I will assume the answer is likely to be a yes. So look for that instantly, because it's going to come up time and time again, and this is often point to an impingement, which we're going to go into in a second. But before that, let's talk about the chief muscles that are involved in this. So our main hip flexors we're thinking of, the psoas major, the iliacus, and the rectus femoris. You're going to have other contributions from muscles such as sartorius and tensor fasciae lata, but also a lot of the adductors, in fact all of the adductors apart from adductor magnus, are going to also assist this flexion movement. So let's talk about our P, Q and R, so pain, quality and range. So we can get back to this idea of this pinch we talked about earlier. Let's talk about that first. So that would be a femoral acetabular impingement. So what does that mean? It means the femur, the thigh bone, and the acetabulum, the cup, the socket it sits in, there's a pinching occurring as the thigh comes up. And that can come about for two common reasons. One is overactivity of the hip flexors, which has taken over the role of stability and movement, and is causing the femur, the thigh bone, to anteriorly translate and jam up. The second reason can be from bone actual type, so congenital reasons. So they happen to have an enlarged bony prominence or a shape that means it's going to pinch end of range regardless of how much rehab or anything you did. So that's useful to bear in mind, especially if you have x-ray results that can point you in that direction. You can just explain to the patient what's happening, and you can modify things rather than taking them through a long process which might not get them anywhere. So that's the impingement. So what else could happen? Well, if we think about the hip coming up into flexion, we talked about the muscles involved. So you can have a straightforward tendinopathy or a muscular strain because those muscles are being overworked, so they could be irritated. If we think about osteoarthritis, so in that sort of situation, if it's not too acute, you might find they're getting pain more towards the end of the range as the joint's becoming more compressed and involved, but less likely to have pain through the range, unless everything's acutely flared. If you have an acutely flared condition, you're going to find that it's going to be painful through range anyway. Also, you may find as the patients bring the hip up into flexion, they actually complain about lumbar spine pain. And you might think, well, is that the hip referring to the back, or well, what's happening there? So a common pattern that happens is people learn to associate lumbar extension with hip flexion. So I'm going to pop around the front and just demonstrate that so you understand what I mean. So hopefully you can see this at home. So as I lift my knee up into flexion, what would be useful to happen is a posteriorly tilting pelvis like so. But what people can learn to do is actually anteriorly rotate their pelvis. So as they lift their knee up, they're doing this sort of motion, and their brain learns to pattern this way. And this can end up causing a lot of compression and irritability here. So you could potentially look at something functional like that later to include that as evidence that this might be occurring. So they're the main ones we wanted to go through for our P. So let's talk about Q, the quality. With regards to the quality, there's a few key things we want to look at, maybe three. So the first one is going to be as they bring their leg back down, it becomes very uncomfortable across their hip and it kind of clunks and you might be able to hear it. And this is called anterior snapping hip syndrome. And what's happening is the tissue of the hip flexor tendons is catching on a bony prominence as it comes down, so it just makes a clunk. It's normally harmless, but if things are particularly aggravated in there, it can become painful. So we may need to take that into account and modify lifestyle and our rehab program as appropriate. Another thing to look for is as they bring their hip up, we'll go for this leg, is they actually start to turn it out. And this is a sign that they're potentially getting anterior impingement or hip flexor overdevelopment, and their body has learned to get around the problem. So as they bring it up, you'll just see it turn out. When that happens, ask them to just bring it up more in a straight line, and you're very likely to have this reported pinch in the front. The last one I wanted to talk about is this sort of slow pensive movement or a reluctance or just a general weakness through. And this is likely to be from something that's very, very acutely flared, but particularly a flared hip flexor tendon strain or an acetabular impingement, because there's just such soreness going around the hip flexors. So they're the main ones I wanted to talk about. Let's talk about the range. So the range you're expecting is up to 135 degrees. So now we're going to test active range of motion of the hip into internal rotation. So as a therapist, we're going to stand on the same side of the hip being tested, and our patient is going to be in the supine position. We want to test this at 90 degrees hip flexion. That's going to be our starting position. So we can ask our patient to bring their knee up to their chest, and we can just guide them up. And here we have our starting position. Now, our patient's not going to often know what internal rotation is, so we're going to help them out with a tactile cue and a visual cue. So one way we could do it is say, can you bring your ankle bone here over to touch my hand? That's it. And then from here, we need to add our overpressure. So we're going to put one hand distally. You can come onto sort of the malleoli region or slightly proximal. It doesn't matter too much. The other hand is going to be on the lateral aspect of the knee. From here, we're going to rotate our body outwards, keeping a good ergonomic position, and apply the overpressure like so. So when we're thinking about the chief muscles that are involved in internal rotation, we want to keep it simple and think about three, and that would be tensor fasciae lata, gluteus medius, and gluteus minimus. You will read in different literature, depending on where the hip joint is and what dynamic activity it's doing, you can get contributions from, say, the adductors into internal rotation. But to keep this simple and not complicate our lives to start with, just think of those three key muscles. So let's think about our pain, quality, and range. So thinking about pain, let's visually see what happens here. So if we think about soft tissues that we know are active during this active contraction, they could be irritated. So what's likely to be happening? Well, we know that we could have a muscle lesion at the three muscles we talked about, so that could be one scenario. But more typically, what you're going to find is an anterior pain, and that's normally from the hip flexors associated with acetabular impingement. They will not appreciate the fibers being twisted if they're already acutely inflamed, so you can get that referral pain here. Similarly, towards the adductors can also not appreciate this torquing motion as well. And if we think of the joint, then we have a few scenarios here. So as the patient internally rotates, you may have pain referral either anteriorly, laterally, or posteriorly, and that can all come from the joint itself. Now, the typical ones we want to think about are the intra-articular lesions. So the main one is going to be osteoarthritis, and the other one could be something such as a labral tear. Then let's move on to our quality. So generally, there's going to be a couple of scenarios you see. One is going to be a coordination issue because the patient's not familiar with the test. You may see as they try and turn in, what actually happens is they just hip hike up a lot. But that doesn't necessarily tell us that it's abnormal, it just means that's how they've chosen to do it. And the other scenario is that they just can't really go that far, and that's likely to be because the range is restricted, and thus because the range is restricted, the quality comes down because the joint and the muscles don't have that freedom to play. And whilst we're speaking about range, the typical range we'll be expecting, if you look in the literature, will be about 45 degrees. In clinic, however, we find that it's often a little bit less than this. We would be thinking more between sort of 35 and 40 as being a very typical thing. So please don't necessarily take it as a true finding if they're not able to achieve that full 45. So now we're going to test active range of motion of the hip into external rotation. So as a therapist, we're going to stand on the same side of the hip being tested, and our patient is going to be in the supine position. We're going to start the test from a 90-degree hip flexion position. So we can ask the patient to bring their knee up to the chest and we can guide their leg to the desired position. Our patient's not likely to know what external rotation is, so it's helpful either to demonstrate how it is, for instance, or use a tapping and say, bring your heel bone over towards my fingers, or you could, for instance, say, bring your heel to touch my hand. Anything like this will do as long as it gets the desired effect. Once we have the end range, so bring your heel over this way, keep coming, keep coming, keep coming. We want to add our overpressure. So we're going to have one hand on the distal ankle and the other hand supporting the knee. And we're going to guide in further that way. A little pro tip here is try and appreciate the movement of the hip into external rotation. If you keep going afterwards as you add your overpressure, you may feel some slackening off at the knee. And that's going to be from ligamentous laxity here. So you can trick yourself into thinking the hip's going a lot further than it is, but that last bit of range you're seeing there, that's purely knee, that's not hip. So bear that in mind when you're testing. So let's think about the chief muscles that are involved in external rotation. This is a longer list, so you're going to have the internal deep lateral rotators. So we've got the gemellus superior, inferior, the obturator internus and externus. We have piriformis. We also have contributions from sartorius and gluteus maximus are all going to be involved in this. So let's think about our P, Q and R. So pain, quality and range. So let's break this down into a muscular versus joint thing. So if the patient's performing external rotation, it makes sense that any of the muscles that are creating that movement could be irritated muscles, and thus pain is created when they complete this movement. If we think about the joint, then you're likely to find it's not going to be, let's talk about the ones it's not going to be so we're not confusing things here. We've talked a lot about acetabular impingement. It's less likely to be this because as we externally rotate here, more space is being created here. So we're not thinking that one. We're also less likely to jump to the conclusion of osteoarthritis because it's not one that's normally affected by the capsular pattern. We could be something intra-articular like a labral tear, so we could think about that. And the other one that it may well be is greater trochanteric pain syndrome, which you are going to likely to link and identify by the pain being referred around the posterolateral greater trochanter region. So that's that bumpy prominence on the outer aspect of the thigh. If we think of quality, depending if they have very little range, the quality is going to be poor because they're going to have to move from somewhere else to achieve it. And if it's a muscular lesion, you may find it might be very sore, so they may be reluctant to move into it. But you're not likely to see any sort of weird or wonderful shaking or anything else of that type. So really it's going to be patient specific, but there's not really that many key things to look out for other than those two. And the expected range is going to be 45 degrees if you look in the literature. Through clinic and testing this on hundreds and hundreds of people, we find that often a normal lateral rotation can go a bit further than that, so it's useful to bear that in mind too. So now we're going to look at testing active range of movement of the hip into abduction. So as a therapist, we're going to stand on the same side of the hip being tested, and our patient is going to be in a supine position. So how do we get the patient to complete the test? Well, you can use your own ways. If you wanted to, you can ask, say, what we're going to do is we're going to just be taking your leg out to the side. So I'd like you to slide your leg out this way as far as you can. A useful prompt is to ask them to keep their toes facing up towards the ceiling or keep their kneecap facing up towards the ceiling. So if we can ask Polly, so if you can lift your leg out to the side, keep your kneecap facing up as far as you feel comfortable to go. Once we have the end range position here, we're going to complete our overpressure. So the way we're going to do that is we're going to put one hand distally. We can come above the malleolus, so proximal to there. You may want to just tuck your thumb under so you're not too grippy. You want a nice soft lumbrical grip. The other hand is going to stabilize on the pelvis, and we're just going to rotate our bodies and take it into that bit further abduction. If you can see my handling here, like so. So there. So let's talk about the muscles that are involved in abduction. Well, the main ones we're thinking about are the tensor fasciae lata, gluteus medius, and gluteus minimus. So let's talk about our P, Q, and R, pain, quality, and range. So if we think about this active AB abduction movement, we can think a lot about muscles and if they're causing a problem. And indeed they do, and often it will present as this greater trochanteric pain syndrome, so this pain sitting on or posterolateral to the greater trochanter. And this makes sense because the chief abduction muscles will actually insert into this greater trochanter, so it makes sense that in and around that area is getting aggravated as it contracts. Another site of pain, not being just the lateral one, could be in the adductor region. And the reason this could be is because if we have an irritated soft tissue in the adductors, it might not appreciate being lengthened passively through this process, or indeed if it's slightly contracting just to stabilize. So that could be a source of pain. We also want to consider the possibility of osteoarthritis. Now, abduction is part of the capsular pattern, but it's not one of the chief ones you run to, so we're not thinking immediately in our thought process it's this, but we could see joint referral pain across the groin, lateral or posterior, from an irritation to an osteoarthritic component. So that takes care of our P for the chief ones we're thinking about. If we think about quality, so if someone has a very acute gluteal tendinopathy, then you may find that they're not very able to abduct very far at all. They might just get to this kind of short distance, or may not even, in severe cases, not move the heel at all and just complain of a lot of pain. But provided it's not hyperacute, they will be able to do the movement. It's not going to be really slow and juddery or anything, but they'll just complain, and you'll see it in their face, and they'll report this pain here as they do it. Now, another thing to look out for with regards to the quality is this cheating lateral rotation movement. So what will happen is the patient will roll out into lateral rotation and then come out this way. There's a couple of reasons they'll like to do that. One is if they have a gluteal tendinopathy, they can get away from using this as the chief activation. So as the foot turns out here, we can start to fire more from hip flexors coming out. So they might want to do it so they can avoid gluteal activation more. The other reason they might want to do it is you will be able to get more clearance in the hip joint this way. So because we're rotating the femur, the thigh bone, we're going to get a different aspect of it articulating here, and you're going to be able to go much further. So if there's a problem with the aspect of the joint here and it's causing compression or irritation inside, this is a great way to cheat and get out of it and make it look like everything's actually fine when it's not. So do look out for that. And indeed, when you're doing your testing, you could always ask them to do both, so you can make a comparison. You can see what happens if they do it normally versus turning out, and that might help you with understanding their condition. So let's talk about range. So the expected range is around 40 degrees. In clinic, I would expect to see potentially more towards the 45 region, especially if you're working with anyone flexible, hypermobility, gymnastic types, then you're of course going to see a lot more than that 45 degrees. So now we're going to test active range of motion of the hip into adduction. So as a therapist, we're going to stand on the same side of the joint being tested, and our patient is going to be in the supine position. Now we're going to need the non-testing leg to be out of the way for this one if we can. So we can have a pure adduction movement, or more of a pure adduction movement. So there's a couple of ways we can do it. One, we can ask the patient to just cross this leg over, or if they're not able to do that for whatever reason, be it they've got a painful side this side or whatnot, we can hold and support their leg for them here whilst they complete it. So because we know Polly can do it, we're just going to get her to leave her leg there. So with our testing leg, this right leg, we ask her to bring her heel as far across to the other side of the bed as she can. And that gives us our adduction movement. From here we want to add our overpressure. So we're going to have one hand just above the malleoli. The other hand is going to come onto the side of the hip, around the ilium, and just block movement here. And we can add our overpressure by pushing the leg into further adduction. So let's talk about the chief muscles involved in this adduction motion, so the adduction. Well, that's going to be our adductors, unsurprisingly. And there's quite a few of them, so when you're starting out, a useful mnemonic to remember them is 3 ducts peck at grass. So your 3 ducts are adductor longus, adductor brevis, and adductor magnus. And the peck at grass refers to pectineus and gracilis. So that's a nice way to remember those. Now let's talk about our P, Q, and R, so pain, quality, and range. So with regards to pain, there's going to be a couple of pathologies that are going to come up time and time again. One, unsurprisingly, is an adductor strain or an adductor tendinopathy, and that's because it's the adductors, as we just spoken about, being contracted and moving. So if they're irritated, it's likely to get pain. And where would we expect to see the pain? Well, that's going to be somewhere along the adductor line. Most commonly, it's going to be in the inside of the groin or even on the sort of front aspect here, where adductor longus comes in and originates from. The other place you want to think about for pain is the passive lengthening that's occurring here on the gluteals. We've talked a lot about greater trochanteric pain syndrome. Well, it's not just active contraction of the abductors that can irritate it, it's also lengthening them out. So if you imagine you've got very angry, inflamed tendinopathy here, it's not going to like you moving and stressing those structures, it's going to send those signals up to the brain and we're going to get a pain output. With regards to Q, quality. So unless this is a very hyperacute condition, either for the adductors or the abductors, they're going to be able to move their leg across just fine. However, if their range is restricted in the abductors, you may find that as they try and complete the movement, they have a big hip hike here, and that's in order to try and create more movement so they can achieve it. So have a look out for that pattern. With regards to the range, we're expecting around 25 degrees. So now we're going to go through active range of motion of the hip into extension. So as the therapist, we're going to be standing behind the patient. And then the patient is going to be side lying with the affected hip up. Now you can of course test this prone, and there are pros and cons to doing both of this. So if you're prone, you could argue that the pelvis is more stable and you're getting more of an accurate reading on the hip extension. However, when it comes to your overpressure and getting a feel for what's going on and checking in with your patient, it's easier and more convenient to do it in side lying. So that's why we've chosen side lying today. So the instructions we give to our patient are to straighten the knee and then to bring your heel as far back as you can, trying not to bend your back. And that creates our hip extension. From here, we're going to add our overpressure. The way we're going to do that is we're going to take our hand and we're going to loop it around. So we're resting the leg on our forearm. The other hand is going to come and block at the pelvis so we don't end up creating loads and loads of lumbar extension. We're testing the hip, so we want to isolate the hip. So it's going to be sort of upper gluteals, and then we're going to turn our body to create that extra extension with our overpressure. So let's think about the muscles that are involved in this. Well, the main muscles we're thinking about are the gluteus maximus and the hamstrings, so the semimembranosus, semitendinosus, and biceps femoris. You're also going to have a contribution from adductor magnus, because that's also a powerful hip extensor. And let's not forget that you're going to have stabilizing and synergistic help from lumbar erectors, so any sort of spinal extensors could come into play too. Now let's think about our P, Q, and R, so our pain, quality, and range. So as with all these active movements, it could be the muscles involved that are causing the problem and pathology. So if there's been a glute max strain or a lumbar spinal erector pain, that could come on during this movement because we know they are involved. Also, we could be getting upper hamstring pain. So the proximal hamstrings will be pulling hard to pull that hip into extension, so we could have pain located around there too. We also want to think a little bit more out of the box, but I'll throw it in seeing as I've started anyway, is if you have compression in the sciatic nerve, you may find that gluteal contraction forcing the hip into more extension may compress it. So you could have some irritation, so that's something else you could consider. Also, we want to think about anteriorly, i.e. in the front of the hip, we'll be getting a passive lengthening on the hip flexors. So if we have an irritable tendinopathy there, you may get some pain referral on the anterior, the front aspect of the hip. In terms of quality, so the main thing you're going to be looking out for with the quality of movement is where it's happening from. Is it happening more lumbar spine? Is it happening more hip? That's the main thing you want to be thinking about. So if we ask Polly to straighten her knee and to take her leg back, then that looks pretty nice. I'm not seeing too much lumbar movement there, and this looks like it's coming from the hip. So if we get Polly to come back in, can you try and do that and just use your lumbar spine so the people at home can see what happens here? And you'll see you'll see the pelvis start to rotate, you'll see this really starting to extend here. And we don't know how much the hip is doing versus the lumbar spine. And this is a very common presentation for people that have spinal dysfunction or any sort of pathology around there, or they've got bad lifting and moving habits. They may start to learn to move everything from their low back rather than their hip. And indeed, as we get older and the hips become more stiff, we'll have even more prevalence of movement and hyperextension here at the lumbar spine. And then finally, we're talking about the range. So the expected range for this is around 20 degrees. Active range of motion of the hip summary. Start your active range of motion assessment by clearing the lumbar spine. Then complete your assessment of the active range of motion of the patient's hip by looking at active flexion, abduction, adduction, internal rotation, external rotation, and extension. Make yourself familiar with the different patient and therapist positions, the method of applying overpressure, as well as the muscles involved in the movement. When looking at your active range of motion, look for P, Q, and R: pain, quality of movement, and range of movement. And that concludes our video on active range of motion testing for the hip. From here, we'd move on to testing passive range of motion of the hip. And by comparing our active range of motion and our passive range of motion, we can see if it's more likely that a contractile or non-contractile structure is responsible for our patient's condition. This, alongside your other tests such as resisted testing and palpation, will further clarify your patient diagnosis. If you're not sure on the interpretations of active range of motion and passive range of motion, we suggest you look at our videos titled Why Test Active Range of Motion and Why Test Passive Range of Motion. So if we take a moment to do that, get our heads around it and come back and join us for the next video.